Hi to everyone, and thank you for joining our webinar today on Comprehensive Epilepsy Centers. What are they and why are they important? Hosted by the Epilepsy Foundation with support from Jazz Pharmaceuticals, Ultragenyx, and the Rare Epilepsy Network. I'm honored to introduce our panelists today, Dr. Scott Perry of Cook Children's Hospital, the Medical Director for Neurology, Co-Director of the Jane and Justin Neuroscience Center, and Medical Director of the Genetic Epilepsy Clinic at Cook Children's Hospital, Jill Hawkins, Founder and President of the FAM 177A1 Research Fund, and a mother of 2 children with a rare epilepsy, and Emily Sakine, also a mother of a child with epilepsy. Your questions today are very welcome and encouraged. Please submit those via the Q&A function in this Zoom, and you'll find that in your Zoom menu where you have the option to add to the chat, the Q&A, or leave the meeting. So use that Q&A function and we'll do our best to get all of the questions answered. With that, Dr. Perry, you're very welcome to begin. So I'll stop my share and you can start.
All right, thank you very much. 1 second here. There you go. All right. So thanks, Kathleen, for inviting me to talk to you about Comprehensive Epilepsy Centers and what they are and why they're important, why you need to know about them, and how they can be helpful for you. As Kathleen said, I am at the Justin Institute for Mind Health at Cook Children's in Fort Worth, Texas, and ran our Comprehensive Epilepsy Center for several years before I took this current position. So what we want to talk about is they're really simple objectives. First, we just talk about what a comprehensive epilepsy center is and how it's different from other places where you might get care for epilepsy, and then discuss why the evaluation and the care provided at an epilepsy center is important. And then most importantly, after we talk about that, review how do you find one? How do you know you're at one? So the first would be like, why would you need to be referred for to an epilepsy center? And there's a lot of reasons. The next 2 slides will go over some of those possible reasons. The first and the most obvious, and the ones people talk about the most, is if you have drug-resistant epilepsy, also known as intractable epilepsy or pharmacoresistant epilepsy, or epilepsy that simply has not responded to 2 appropriately chosen and dosed anti-seizure medications. And why is that? Well, the reason for that is because in general, if you take epilepsies across the board, the likelihood of becoming seizure-free with the first drug you ever try is about 50%. For the 50% that don't respond to that first drug, if they try a second drug, another 12% tend to respond to the second drug. So the majority of people will respond to one of the first 2 drugs they're treated with. But after that time, the likelihood of responding meaning becoming seizure-free goes down less and less. And so at that point, you want to start to be thinking about, number 1, are you using the right meds? Are you using the right doses? Are meds even the right treatment? Maybe we need to be thinking about other ways to treat it. I put on this slide the 2003 American Academy of Neurology guideline for the evaluation of epilepsy surgery. And there you see that guideline says that referral to a surgical epilepsy center, of which I'll go over the categories of epilepsy center, but most of them can partake in some amount of epilepsy surgery. A referral to those centers should be made after failure of appropriately used first-line drugs. And actually that piece is kind of key too. And many times you may need an epilepsy center to understand what appropriate drug is. But just to give you a simple example, we may see people who have a diagnosis of juvenile myoclonic epilepsy, for example, which is a very common epilepsy type. And they have failed 2 drugs, but those 2 drugs happen to be carbamazepine and oxcarbazepine, both drugs which are not appropriate for that condition. And if we instead used drugs that were appropriate, they would not maybe have failed. So these are just the kinds of thought processes that might go in to these evaluations and treatment. Some of the other reasons why one might need a referral to an epilepsy center are listed here. This is from the 2014 American Academy of Neurology Quality Measures. So these are basically characteristics of people where this referral may be necessary. So as I said, poorly controlled after 2 medications. Maybe the medications are presenting with unacceptable side effects. If there's a structural lesion present, the reason for that is because structural lesion is often amenable to surgical therapy. And so you want to know if that option is there, and you might want to know about that even earlier than having failed 2 meds. If there are other comorbid problems, so other maybe mental health or behavioral health comorbidities that will require more complex management. If there's uncertainty about why you have epilepsy or what the epilepsy syndrome is, and then if you're under the care of a general neurologist, but you failed to achieve control within a year, the AAN has recommended that seeking care at an epilepsy center is worthwhile. So what is an epilepsy center? I mean, it's pretty easy to define. An epilepsy center is a program that offers a more comprehensive care to people with epilepsy. And that comprehensive care consists of 2 main factors. That's usually people and resources. Resources meaning the tools of which we use to investigate and treat. So the types of people you would see in an epilepsy center on the team would be epileptologists. So, an epileptologist is a neurologist who has done additional training specifically in the care evaluation of epilepsy in particular. And then some of us who then train in epilepsy spend more time focusing on even certain treatments. For instance, I focus on genetic epilepsy treatments and epilepsy surgery. Others may focus on other portions of epileptology. You'll find neurosurgeons in epilepsy centers, neuropsychologists, EEG technicians with special training, social workers, dietitians, nurse specialists, etc. And then the epilepsy centers should be providing, they'll have for you the resources and again, the treatment options that are beyond just medications. So these will be centers that are very experienced at dealing with drug-resistant epilepsy. They are experienced in epilepsy surgical evaluations, neuromodulation techniques like vagus nerve stimulation, responsive neurostimulation, and deep brain stimulation. Dietary therapies like the keto diet, modified Atkins, low glycemic diet. Many of them will likely have investigative trials for new treatments, new drugs, for example. They should have resources that can help with, as I said, the other comorbidities that we might encounter, specifically mental and behavioral health comorbidities. And then importantly, be able to connect you to support groups, not just support groups for epilepsy in general, but maybe for your particular epilepsy syndrome, or as I do oftentimes when I'm talking about surgery, connecting you to other families that have undergone these same evaluations and same treatments, so that you can get some feedback on what the experience is like and what they experienced in going through that evaluation. When you're looking at epilepsy centers in the United States, most of our epilepsy centers will be accredited or graded according to the National Association of Epilepsy Centers, or the NAEC levels. And so I broke down kind of how they look at those levels. So a level 1 center is really, level 1 is really just initial care. So you've gone to your primary care physician or the emergency room, and they've done initial workup that might involve some amount of imaging, maybe an EEG, a history exam, that kind of stuff. A level 2 is consultation with a neurologist. So now you're working with a general neurologist who certainly has experience in epilepsy. Epilepsy is a very common diagnosis in neurology. So most neurologists have a lot of experience with it. And then level 3 and 4 are true epilepsy center evaluations. The accreditation process of the NAEC basically now consists of surveys to determine the resources that we have available. So they're looking at our epilepsy monitoring units and how they're run. How many techs do we have? Are they available 24/7 to review EEGs? Do we have, what imaging modalities do we have? MRI, or do we have MRI plus PET scans, SPECT scans, functional MRIs, MEG scans, et cetera, other staff, and then safety and treatment protocols within our systems. Just to go into that a little bit deeper, this is straight from their website, how they define the 3 and 4 centers. So a level 3 center, I highlighted the key points there, will provide a basic range of medical, neuropsychological, and psychosocial services. These are centers that can offer evaluation for epilepsy surgery. These are often straightforward resective epilepsy surgeries. And what is straightforward surgery? Straightforward is when maybe there's a lesion that is easily removable. It's not in a eloquent part of brain, meaning a part of brain where there may be some adverse consequences, such as think weakness, vision changes, speech changes, and it's congruent with our EEG findings. And they may be able to implant things like the vagus nerve stimulator. Importantly, level 3 centers do not do invasive evaluations. So what is an invasive evaluation? An invasive evaluation, invasive surgical evaluation for epilepsy is when, with our initial workup, we have an idea where the problem is, but we are not satisfied that we have identified it well enough, such that we feel that we need to put electrodes not on the scalp like you have with typical EEG, but we actually put the electrodes in the brain into the different areas that we're interested in studying to further not only solidify where the seizures are coming from, but hopefully to find the smallest absolute area that needs to be treated. So then a level 4 center, the difference there is that we offer, in general, the full scale of intensive neurodiagnostic monitoring. We have extensive medical, neuropsychological, and psychosocial treatments in these centers. And we offer not only invasive monitoring, but the full range of surgical procedures for epilepsy. And the full range is, multiple things we can do from an epilepsy surgery standpoint. You have not only resective surgeries where you may remove the area of the brain that's causing seizures, but we may have neuromodulation techniques like responsive neurostimulation, where we implant a device over that area to record and stimulate for seizures, or thermal ablation or laser ablation, where we burn the area, or palliative procedures like corpus callosotomies, where we disconnect the hemispheres from each other. Things of that nature. So a level 4 center should have really the full breadth of options to consider when talking about drug-resistant epilepsies and other epilepsies too. It doesn't need to be necessarily drug-resistant. Some of the epilepsies are just more complicated and maybe need more specific treatments, investigational treatments, and that's where these centers come in. So how do you find an epilepsy center? It's fairly simple. You can actually get to these links from the Epilepsy Foundation's page, but this is the link from the QR code there to get you to the National Association of Epilepsy Centers. So in the US, that will help you identify where those are. And as you see, there's 260 centers accredited in the United States by this organization. So you can go there, you can type in your zip code, and it will tell you the one that is closest to you, and you can see what level they are. And how that corresponds to maybe what services you need. So that's a very quick kind of overview of what an epilepsy center is and how it might be different and why you might need it. And I'll be happy to stick around and take questions now or at the end of this presentation if you have any about this. Thank you very much.
Thank you so much, Dr. Perry. And I'd encourage anyone interested in asking a question, again, please use that Q&A function in the Zoom, and we'll make sure to get those. I'm not seeing any right now. So we'll keep Dr. Perry in the loop and add questions at the end. At this stage, I will introduce Jill Hawkins. Jill, if you'd like to share your screen and begin.
Sure. Thanks, Kathleen. Thank you, Dr. Perry. And thank you to the Epilepsy Foundation for including me today and for the important work that you're doing. My name is Jill Hawkins, and I live in Seattle, Washington with my husband, Doug, and our 3 children, 2 of whom have seizures. That's Charlotte. She's 17. That's Cooper. He's 12. And that's Cooper later on when he's been in the hospital multiple times for seizures. So Charlotte and Cooper were 2 of the first children diagnosed with a recently discovered disorder caused by disruption to their FAM177A1 gene. We currently know of 13 other patients with this disorder, and about half of them have seizures. Although Charlotte and Cooper have always suffered from a range of issues, I was relieved that for many years we didn't check the seizure box. And then when Cooper was 6 and Charlotte was 11, they started seizing. Charlotte, fortunately, has had only a handful of seizures, and she's had several EEGs that are relatively unremarkable and stable. She's never taken anti-epileptic drugs. Cooper started out having occasional tonic-clonic seizures, but unfortunately his epilepsy has progressed to multiple types of uncontrolled daily seizures, resulting in 8 hospitalizations in the last 18 months. We've tried and failed numerous seizure meds and a keto diet trial. He had a VNS implanted about a year ago. I'm happy to report that in the last month, we have seen only 1 seizure. I'm cautiously optimistic, as we're not exactly sure why he's improved, and we're always waiting for the other shoe to drop. So when I was asked to participate in this panel, one of my first thoughts was, the Seattle Children's, our local hospital, even have a comprehensive epilepsy center? Because I've never walked through the grand gates of the center that I envisioned when I heard the term Comprehensive Epilepsy Center. Well, it turns out that they do, and it turns out that we have utilized just about everything that they offer. My children have received good care from caring doctors, and I'm grateful to have the breadth of treatments and this high level of expertise nearby. But now that I know what a comprehensive epilepsy center is, I wish that our introduction had been a bit more proactive. When Cooper's seizure started, we were given some general information about epilepsy, and he was seen by a neurologist. Then his seizures progressed. As his seizures progressed, he was ultimately hospitalized with uncontrolled seizures. In hindsight, I think this is when we passed unknowingly through the virtual gates of the Comprehensive Epilepsy Center. There are aspects of our epilepsy journey that are a double-edged sword. Although Cooper had had a couple of brief sedated EEGs, my understanding is that these were not very informative. But when Cooper was hospitalized, he was so lethargic from all the seizures that we were able to get an extended video EEG that captured the data needed to accurately diagnose him with Lennox-Gastaut syndrome. What I'm learning from Dr. Perry is this kind of technology isn't available at all hospitals and in all centers. I didn't realize kind of what a gift it was to have this nearby. Although I've since learned that Lennox-Gastaut is a brutal condition, in the moment, this felt like a win for a couple of reasons. Prior to this, we are struggling to dose over-the-counter cannabinoids. The Lennox-Gastaut diagnosis gave us access to the prescription version of Epidiolex, relieving the burden on me of playing pharmacist. Epidiolex worked for a while, but then it didn't. Our medication odyssey is a story for another time. Another win was that the LGS diagnosis introduced me to the Lennox-Gastaut Foundation, a highly informed and supportive advocacy group, and other advocacy groups like the Epilepsy Foundation, Rare Epilepsy Network, which have been amazing resources for me. And I've learned a lot from them personally, and I'm able to pass that knowledge on to our FAM 177A1 community. Finally, another win was the coordination of care. It's a big challenge for families like ours that have really medically complex kids. But having everyone in the same center is a real benefit. For us, that's included epileptologists, neurosurgeons, dietitians, geneticists, and then outside of the center, but in the same hospital, rheumatologists and neuroinflammatory specialists as well. Barriers, I'll mention a couple. I feel really fortunate that there haven't been too many barriers, I think in part because of our proximity to this center. But a couple of things I wish were different. It took a hospitalization to onboard an epileptologist. I wish we had consulted with one sooner. I wasn't told about the Comprehensive Epilepsy Center, or whatever Seattle Children's refers to it as. And I wish I had had just more information about the range of options that were out there, rather than kind of it coming at us in a piecemeal way, and a more reactive kind of way. So I'll stop there. happy to answer questions, and then I'm eager to hear Emily's story as well.
Thank you so much, Jill. And I am starting to see questions come through in the chat and the Q&A function. But what I'll do is I'll ask Emily to go ahead and present, and then we'll do a comprehensive Q&A and discussion all together. So Emily, over to you.
Sure. Thank you so much, Kathleen, for having me, and Dr. Perry and Jill. We have a different diagnosis, but sort of a similar story on how we stumbled upon a comprehensive epilepsy center. And as Dr. Perry was presenting, I was really struck by the number of providers that he listed, because I feel like we've used every one of those at the Comprehensive Epilepsy Center that we have brought our daughter, Naomi, to. Just a bit of background about us. We live in the Metro DC area in Maryland, and I have two children. Our oldest, Naomi, was diagnosed with epilepsy when she was 6 years old, and we have a younger son who is now 12. And Naomi's diagnosis was really unremarkable and well controlled when she was young. We started noticing very short staring spells, and brought her to a local neurologist that was just on our pediatrician's like referral list, and ended up putting her on a medication. She was diagnosed with what they thought was childhood absence, and she was well controlled for many years, even came off of medication for 2 years. But then when she was in the 4th grade, we started seeing the absence again, put her back on the medication that she was on previously. And then about a year later, she had her first tonic-clonic seizure. And at that time, her neurologist who we had been seeing ended up retiring. So we were with kind of someone who didn't know her as well, who just happened to go on maternity leave. It was all just sort of a bad like set of circumstances. And so, as you know, when seizures start, you start adding on medications. We started layering on more than one medication to try help control the tonic-clonic seizures. And then we started going down the road of experiencing very bad side effects. She, our daughter really, I felt like, became a zombie for, a good academic year, lost a lot of standing academically. And it was kind of out of desperation that I turned to a comprehensive epilepsy center in the DC area. I felt like our neurology team that she was with just kind of, I just wasn't getting anywhere. I wanted to keep trying more meds, and they said, some people's seizures just aren't able to be controlled. And, as a mother, I just wasn't able to accept that sort of roadblock. I needed to try more. I, wanted to be sure she had the best care possible. And it was just very hard watching my, otherwise normally functioning daughter, progress to, this sort of zombie state that she was living in. So we made our first appointment at a comprehensive epilepsy center. And the first thing I noticed was during that evaluation, there were several providers that all came into the room. There was the epileptologist, but there was someone who sort of helped with like educational issues. And there were like maybe 5 other people, and it was kind of a blur. So I don't remember exactly all of it, but we basically went through a list of drugs that, he reviewed all of her EEGs that she had, and also referred us to a neurologist who specialized in genetics for some genetic testing, because we had never done that before. They also referred us to a neurologist who oversaw their diet program, to talk about putting her on like modified Atkins. And then, epilepsy is just, honestly, I like to like consider it sort of like an onion. It's like, it affects like so many parts of, so many facets of like a child's like development and life and functioning. And you have to literally keep peeling back these layers and problems that pop up. So as we were trying, lots of different meds, our daughter mentioned that she was she was depressed, she was not feeling well, and then they referred us to a psychologist who was able to provide mental health counseling. They stayed with her until she was done, getting onto a med that worked best for her, because sometimes it's very hard to know if it's the meds that are impacting something, or is it depression, like what is it? And then I think one of the parts that's been the most helpful to us is, well, actually two things. The neuropsychology team sat down with her and did a full neuropsych test to evaluate where she was, which really helped me with school placement and making sure she had the accommodations that she needed at school, and is right now helping us figure out where she should go for college. So that information has just been like so invaluable. And then I would say the last potentially most impactful thing to Naomi has been the summer camp that the Comprehensive Epilepsy Center runs. As soon as Naomi had her first large seizure, I immediately, as soon as we got there, I said, you have a summer camp, like Naomi needs to go. She needs to meet other people. She needs to be well supported and have an outlet of other people to talk to. And over the years, she was a CIT there last summer. She's progressed in a way that has allowed her to really learn how to take care of her disease and manage herself, manage her meds, and also learn how to take care of other people and, be a good role model for other kids who are also dealing with, their seizure journeys. So I can't speak highly enough of Comprehensive Epilepsy Centers, and I'm very proud to say that Naomi has been seizure-free. She was seizure-free after we switched for about 3 years, and then had another instance where her meds just stopped working for whatever reason. We had to find completely new meds, but she's been seizure-free for another 1.5 years and is driving now. And I just don't think that I don't think that she would have had nearly as good of an outcome had we not made that switch to a comprehensive epilepsy center.
Emily, thank you so much. And Jill and Emily, I think you both raised really great points in terms of, just kind of having to stumble upon the existence of comprehensive epilepsy centers. And Emily, I'm curious, I don't think you mentioned, how did you become aware that there was such a thing after seeing a general neurologist?
I think that I just started looking around, and I don't think I really knew what a comprehensive epilepsy center was per se, but I started looking at different practices in the area that I could take my daughter to. And I immediately I was struck by the number of providers and the number of resources available at this comprehensive epilepsy center versus where we were previously. And I just decided that it was something that we needed to try. So I honestly don't think it was super intentional. I just in sort of desperation of trying to find, a better med path for her.
Yeah.
Mhm.
Yeah, you're both kind of flagging the gap that we still need to continue working to fill, which is awareness from in the general neurology and primary practice clinics of the existence of these types of centers, that families can be referred earlier in the journey. Jill, you raised a really great point that it came quite late for you and your family, and you just kind of stumbled upon it. So thank you for those. And I'm seeing a question, and I think this for Dr. Perry. Is there European equivalent to the US-based comprehensive epilepsy centers, and how are research and findings across centers, are they shared broadly in your finding?
So with regards to Europe, I'll admit I am not completely I'm not completely aware of all of their processes that they use in Europe. They no doubt have a European Association of Epilepsy Centers. What it requires to become a member of that and be graded, I do not know. They also have some very good networks like the EpiCare network in Europe, which is a network of I don't know how many now European epilepsy centers that do work together. They have a lot of different research projects that they work with across countries. So a lot of data sharing from that aspect. And then, you know, in the United States, one of the things I was thinking that I didn't mention in the United States is that, you know, at least in the pediatric world, we're actually a fairly small community. You know, we all know each other. A lot of us know each other quite well. Many of us are members of the Pediatric Epilepsy Research Consortium. And so we all work together frequently. We actually share a lot of patients that maybe go between centers and share ideas about, you know, how to treat them. And so I think that's another thing you may find at an epilepsy center that you don't find elsewhere, is that they have those connections, right? Because I do genetic epilepsy. I cannot be an expert in every single genetic condition. Jill has introduced me today to one I'm not aware of that I am going to be learning more about soon, right? So, you know, so it's very important to have friends in the epilepsy world, and we do, and we can connect. I think another thing that Jill brought up that I think is important for people to recognize is that you might not walk through the door with a big sign over that says the Comprehensive Epilepsy Center, you know, because especially for us in these larger centers, we don't really think of it as, we almost don't think of it as an individual division of our program. It's just it's just our epileptologist, you know, it's our epilepsy center. So a lot of the bigger programs, especially like those associated with academic facilities, if you're seeing an epileptologist, you are probably being seen by the epilepsy center. And if you are not being seen by an epileptologist, I can assure you in most of those places, the general neurologists are probably at least working with the epileptologist. I mean, that's admittingly one of the problems we have here, right? I mean, access and resources are limited. There's only so many epileptologists. So a lot of times it is working with our general neurologist and helping them and making sure that they're doing everything that can be done while we're waiting to be able to get them into us. So.
And that raises another question from things that Jill and Emily shared in terms of, they both have teenagers, and they both have, you know, that were once children. I know Jill has still a young son who's not yet a teenager or moving towards adulthood. Is care at Comprehensive Epilepsy Centers better set to facilitate transitions between childhood and adult care?
Well, I'll love to hear what answers are of those who have had to transition from there, because we might think we do a good job, but I doubt we do. You know, it's really it's tough. It is transition of care is tough for a few reasons. In the world that I live in, transition is tough because the patients that I take care of have very rare disorders that the adult world is not familiar with. And so it really takes building a strong transition program from the ground up to do that, which is what we had to do here. So we do have that. Most pediatric epilepsy centers, have identified adult providers that they are, familiar with and like to refer to, but I will still say it can't be an easy process. It's not as simple as one day you turn 18 and you walk out the door and go to another doctor. It just doesn't work that way.
And Jill and Emily, I'd welcome your additions to that in terms of transition between pediatric and adult care for your teenagers and for your younger ones. How has that been, or and did it vary before and after you got to an epilepsy center?
Well, I'm still in denial that my kids are going to become adults. So we're going to keep them at a children's hospital just as long as we can. But I do see the signs up in the office that say, we will help you. Like, we have a plan in place. There's actually one that says we have a 3-year transition plan to adult care. And so I'm like, well, that's reassuring. Like, that's very helpful to know that there's some thought being put to this, and they're hopefully going to hold our hand through it. I don't know what it's going to look like. It's one of those bridges we'll cross soon.
And I don't know what our transition will look like exactly. Someone mentioned to me that once your child's in college, they encourage you to find a neurologist that's, closer to where they are. So I'm assuming there might be some transition coming to us soon, but I'm just not sure. And again, we're like clinging on to that where we are now for as long as we can, because it's just been so good. But hopefully when the time does come, she'll be in a good enough spot to make that transition seamless.
This is an entirely separate webinar on transition of care, no
Yeah.
doubt. The Child Neurology Foundation has a very good laid out a roadmap for transition of care, which begins in early adolescence, is when it should first be talked about, and discussing the steps that need to take place. There are steps as empowering the child to care for themselves and take their own medicines and be responsible for their care. You also have to think of those who can't be responsible for their care and think about how are their decisions going to be made after they turn 18, guardianship, powers of attorney, things like that. And then getting them to the right adult provider to care for them, and making sure they're ready to go, and doing it at a time. For me, it's important to do it at a time where if it doesn't work out, because hey, maybe they're not going to get along with their adult provider as well as you hope they would, and you're going to need to find them another one. So give them some time that you can make that adjustment and make it smooth. So yeah, that's a whole nother webinar, but a great topic.
Definitely
but I will
one to
say
add.
that yes, our epileptologist has been wonderful with like giving us some like technologies that are helping our daughter transition. Like they recommended an embrace watch for her so that it calls us when she's having a seizure, so she can go out and about by herself, which sort of started in middle school. She wanted to go to the mall by herself. She wanted to go, like with friends. And and she's doing like a pre-college program this summer. So we're going to try like living in the dorms, and you're going to use this like app to help, remind yourself to take your meds. So I think that the epileptologist and like our team has like really helped with some, and also just the life skills that she's learned at her summer camp, like have all helped sort of like push her in that direction of independence, which, as you said, it's a long transition, but there've been a lot of resources along the way to help with that.
Thank each of you for your input on that topic area. There's a question around availability of housing and assisted living communities for people with epilepsy, and are they ever designed around access to an epilepsy center? And I think I'm happy to try and answer that. The Epilepsy Foundation is a national nonprofit organization, and we have regional teams and affiliates in almost every state in the country. And so if you're interested in what local resources, because these vary so widely, and also as Dr. Perry mentioned, there's centers all over the country, but they mightn't be in every major city. So I would recommend visiting epilepsy.com. There's a section where you can find your local Epilepsy Foundation office. They can offer you resources, not only around if there's a center in your location, but additionally, what other community-based resources are available for you. So I'd encourage you to visit epilepsy.com with any questions. And I have a slide a little bit later about our Epilepsy Foundation helpline that's available 24 hours a day, 7 days a week in English and Spanish, and is also a great resource for you to ask those types of questions. And there are also questions around the Lennox-Gastaut syndrome, or LGS. And while we can't get into specifics on cases, I wonder whether anyone on the line has insights that they'd like to share either about the LGS diagnosis, or Dr. Perry a little bit more about RNS or VNS.
Sure. Yeah, I've actually both of the others made two comments during their presentations about their journey that I thought were kind of important, really encapsulated the importance of comprehensive epilepsy centers, right? The first, I think, Jill, you made this comment about getting the diagnosis of Lennox-Gastaut syndrome, and that there's some initial relief. And there is some initial relief with that, right? So what you get potentially from a comprehensive epilepsy center is getting to the syndromic diagnosis if you don't have it already. And so knowing you have Lennox-Gastaut syndrome is super important, because that not only, it it not only tells you what one might expect from prognosis and seizure control standpoint, what kind of seizures may occur, associated comorbid problems, but then it also tells you what kind of treatments are available. Mostly they're available because they have been studied in the condition and shown to work. Not that they're anything special for LGS. All right. But then the second thing she brought up that I think is really important is that next step that I would hope a comprehensive epilepsy center would take, which is that having a diagnosis of LGS is not the end of the journey. That just tells you a syndrome, which is a collection of symptoms. It does not tell us why do you have Lennox-Gastaut syndrome, which is a more important question. Because if we know why, then the treatment may be very specific if, for certain conditions. We're seeing this increasingly in the genetics world, that there may be certain conditions where there are treatments that are super specific to what it is. So I think those are important things. And then as far as, other treatments go, as far as LGS goes, there's a lot of treatments out there that are available. Frankly, for all epilepsies, there's a lot of treatments out there that are available. I don't remember if Emily or Jill was the one that said that their neurologist told them, well, some people just don't achieve seizure freedom, and that is absolutely 100% true. Some people do not achieve seizure freedom, but that does not, you don't wave the white flag until you have gone through every reasonable treatment that has a chance to make you better. Because if I say, hey, here's new drug that has a 3% chance of making you seizure free, well, that's better than zero. So it's at least worth consideration, right? And so I think that's another piece that I would hope you get from an epilepsy center. You don't have to choose every treatment that's out there, but you need to hear about every treatment. In fact, I would say back to LGS, one of the things I do for LGS probably more than anything is take people off of medications, because they have come to me on 6 medications because they're being added and added and added, trying to get control. And, with this wider view of epilepsy, you sit and you say, okay, what are we trying to achieve here? Like, we could be on less meds and have the same amount of seizures and a much better quality of life. So let's go that direction at this point. And I think you need that. Usually you're probably going to find that more in a comprehensive epilepsy center, where they're more used to maybe turning the other direction if we have to, because it means a better quality of life. So
that's interesting you should say that, because the thing that we are attributing Cooper's recent improvement to is taking him off of one of his medications, which seems so counterintuitive.
Yep.
But
sometimes less is more.
And I'll also add that, when we came to a comprehensive epilepsy center, they made us a list of like 10 drugs we could cycle through, and what the plan was, 1, 2, 3, 4, plan A, B, C, like what we could try again. And one of the things that ended up working was not a drug that's routinely prescribed for generalized seizures. It's more used for partial seizures, and it just happened to work. And, I guess, I don't know, sometimes I feel like epilepsy is more of a art than a science, although I know there's a ton of science behind it, but you just have to keep, trying until you find what works.
Dr. Perry, what are the current general guidelines around genetic testing for epilepsy centers?
I'm not sure if it's fair to say there's really any straight guidelines, right? But if there are certain things where I think most of us agree genetic testing is appropriate. Okay, so if you have drug-resistant epilepsy without the etiology identified, you definitely need genetic testing. If you have drug-resistant epilepsy with an MRI that's abnormal but doesn't really explain the full picture, genetic testing is worthwhile. If you have early onset epilepsy, so epilepsy in the first 3 years of life, there's a high rate of genetic etiologies in that group, so those should be tested. If you have epilepsy in the setting of intellectual disabilities, genetic testing is probably very reasonable. If you have epilepsy really well controlled on a single medication, genetic testing is probably much lower yield. but there are certain populations that early onset intellectual disabilities, drug-resistant epilepsies without etiology, where the hit rate for finding a positive finding is probably 30% on average in genetic testing, which can be very informative. And you know, it's becoming increasingly easier to get genetic testing in the U.S. It's by no means easy, but increasingly easier. And you know, sometimes the arguments you get from a payer as an insurance company, why not do it, is because, well, there's not a treatment that's really going to change things, right? But my argument is, well, if there ever is, I won't know to use it because I don't know what this person has, right? So if you don't do the testing, how do you know what you're supposed to be looking for to figure out how to treat it? I think there was a question, actually, I passed on, somebody asked about LGS in adulthood in genetic testing. And I will tell you, I strongly believe that there are, many adults walking around with drug-resistant epilepsy that don't know why they have drug-resistant epilepsy, that deserve genetic testing. There are multiple studies that show that these people have undergone testing, and a high majority, for instance, may have Dravet syndrome, where the drugs they're on, which are sodium channel drugs, are contraindicated in their condition and make them worse. And if we take them off those medicines and put them on the right ones, they can do much better. So it really does change care, and should be something that people pursue.
Another great topic. Thank you, Jill, for raising that question. In that same vein, Dr. Perry, you're talking a lot about how fast the science is evolving. That comes with new medications to market, new devices. There's a question about at-home EEG testing versus what you might be able to get in a center. And can you talk a little bit more about that?
Yeah, at-home testing is super useful. It's very convenient. I mean, I use a ton of it. I'm here in Texas, where my patients could be 8 hours away and still in the same state. And to get testing done for them, it's easier to send one of these companies to their home and do the testing than have them come here. But I have to consider it in certain situations. So, for example, if I'm dealing with a patient who maybe has really short or subtle seizures clinically, maybe they're just quick myoclonic jerks or very brief staring episodes, not seizures where there's tonic-clonic, convulsive type stuff. It's really easy to see on video. If we're dealing with very subtle clinical findings, these home testing is generally not good enough. Because you can imagine if I'm trying to capture an event that's not a seizure, right? So there's nothing on the EEG and the family says, oh, it just happened. If I can't see it on video very well, I can't make sure that I'm looking at the EEG exactly when whatever, the family saw happen. So video is really important for those conditions or for those circumstances. And in that case, inpatient video EEG is probably better because you've got techs that are watching the video, they're moving the camera around and making sure the person's always in the camera. Whereas home, it's going to be 2 stationary cameras, maybe 3. And if you're not standing in front of it, I'm not seeing it. But if you're really just doing it because, maybe what kind of seizures they have, so you're just looking at the EEG basically to see, how much is happening, that's a different story, I think. So there's definitely value in it. You just have to think about the situation. You don't want to waste anyone's time getting something that's not useful. The other thing to think about in kids is if they're super cooperative, great. But if they like to, pick their EEG and take leads off, if the company you're using is not constantly monitoring and available to go out and fix it, you could get the study back and it just be a bunch of artifact that's not really going to tell you anything.
Thank you. It looks like oh, sorry, go ahead, Jill.
Dr. Perry, you mentioned you might have a patient that's 8 hours from your center. So what do you recommend to families that live so far away from a center?
Well, I mean, there's a lot of ways to work with them. It all depends on the center. A lot of the centers have ability to work long distance. It depends. It depends on the states we're talking about and what their medical licensing rules are. So, for instance, I'm licensed in other states besides the state of Texas, so I can do video visits in a few other states where I'm licensed. But if I'm not licensed in the state that they live in, they have to come here, for example. But there are, so those are some options. Some options are also just, most people are in reasonable distance to an epilepsy center where they may be able to do a visit, even video, if they're in the same state or neighboring states. I mean, that's probably the best way. I mean, right now it's still travel. The medical licensing thing is a real problem because the license is necessary for where the patient is being cared for, right? So just because I'm in Texas and this is where I am practicing medicine, it's wherever the patient is residing that the license has to be active. So that's where it can be a problem.
Yeah, so licensing and from I think what we hear from the community too, insurance can be really tricky in terms of reimbursements for people.
Yeah,
do you find that's a barrier?
Yeah, it depends. Like many of the insurances, especially like state Medicaid programs, will want to keep the patients within their state and their state services, and so they have to be able to show that the services they're going to be receiving where they're going to are different than what they could get in their own state. For instance, again, for me, a lot of people are coming here because of genetic epilepsy. If they don't have a genetic epileptologist in the state, then that's a reason that they should be able to get care outside of the state. But it just depends on the circumstance.
Jill, Emily, Dr. Perry, any final thoughts or comments you wanted to make based on any of the questions we've heard or any of the presentations?
I have one more question for Dr. Perry. I feel like I'm capitalizing him, but it's such an honor to be in the room with somebody so in line with, our patient population. Are you doing or how much thought has been given to sort of leveraging what I consider really powerful data that's generated in these epilepsy centers? I'm thinking around these EEGs, around drug efficacy, like we're trying to find biomarkers, like we have these very unique genetic mutations now, and we're trying to find like what makes the EEG maybe super special now about our disease. Or like you mentioned, there's maybe a drug that's not good for a certain genetic condition. So is anybody trying to harness all this data?
So yes, and it's a great idea. It's not simple as you can imagine, right? I mentioned the Pediatric Epilepsy Research Consortium. That organization was really envisioned. Childhood cancer is where it is because the childhood oncology group, the child oncology group, started COG many years ago, right? And their effort was all these places are part of this group. And if you come to one of those hospitals and you have childhood cancer, we have a protocol for you. And it's just research. Everybody is doing research to figure out how to get to the answers. And they generate lots of answers on rare diseases very quickly. PERC was established with the same plan. We all do epilepsy. Let's be collegial. Let's work together. And we have now 65 centers that are part of that group. And what we want to get to is a point where everyone, like we're aware of which patients or which centers with which diagnoses. For things like you're interested in the genetic epilepsies, we want to be able to say, hey, your group wants a natural history study, and you know of only a couple people in Seattle, so Seattle can't make a natural history study with 2 people, right? You need a lot. So, okay, fine. All 65 centers, identify yourself. This is where patients with this condition will go. These are the things we will collect, and you'll collect it a lot faster. I started the epilepsy surgery database as part of this group years ago, and we have 25 centers that collect information now. And, in a few years, we had, over 2,000 patients with epilepsy surgery that we could look at. So it's just a matter of agreeing and working together collegially to collect a lot of data really quickly. So the possibility is there. There's just, you gotta hammer through those barriers.
And I can add to that as well, Jill. The Epilepsy Foundation is also involved in a quality improvement and research, leads a quality improvement and research learning network among epilepsy centers in the United States called the Epilepsy Learning Healthcare System. And it involves both pediatric and adult epilepsy centers. There's also a pediatric exclusive network called the Pediatric Epilepsy Learning Healthcare System. And it's our hope eventually to be intertwining the two learning networks, but it's a way for data to be collected in a standardized way so that it can be reflected upon and acted on in real time, which is a little bit different, that quality improvement piece, a little bit different than traditional research, which may take years to see real practice change implemented. And so, like Dr. Perry said, this is something that I think there's real interest in work being done in, and we hope to see improvements in care and outcomes for all people living with epilepsy, over time for improved outcomes. So that's a great question, and hope that answers. At this time, we are coming up on the top of the hour, so I just want to thank everyone. Let me reshare my slides. I also want to thank our supporting partners in Jazz Pharmaceuticals, Ultragenics, and the Rare Epilepsy Network. Thank you to Dr. Perry, Emily, and Jill for your presentations. A few resources that I just wanted to mention before we wrap up. I mentioned earlier in the webinar that the Epilepsy Foundation has a 24/7 helpline available in both English and Spanish, and those numbers are found at the bottom of the slide. People can reach out for local specific or national resources or connections that they're looking to make to our helpline. So please consider us a resource. The Rare Epilepsy Network that you've heard about a few times on this call, if you've got a genetic or otherwise diagnosed rare epilepsy, the Rare Epilepsy Network, or REN, is also a great resource to families. The National Walk to End Epilepsy is back in Washington, D.C., upcoming on May 6th. And so if you're in the area, we would love to see you. You can register and learn more at walktoendepilepsy.org/DC. And also, I would encourage anyone on the line today to please keep an eye out in your inbox for a feedback survey on this webinar. It's with your input that we're able to continuously improve and look for topics of interest to the community. So appreciate your completing that. And please keep an eye out for the recording of this webinar, which will be made available on the Epilepsy Foundation's YouTube channel in the coming weeks ahead. So thank you everyone for watching, and have a great rest of your day.